With over 4 decades of experience as a healthcare professional, Dr. Joseph Rosado, MD, is also one of the world's most respected authorities on cannabis as a plant-based medicine. Welcome to the show, Dr. Rosado.
Thank you very much. It's a pleasure being here.
Oh, it's great to see you. So today's show is about depression, and I was kind of looking around for some statistics because I know it's fairly prevalent out there here in the United States, probably in the world actually. And I found this, according to the National Institute of Mental Health, in 2017, 7.1% of the population aged 18 and older was suffering from major depression. And also, it's highest in those 18 to 29 years old at 21%, followed by ages 45 to 64. And it seems that women suffer more from depression than men. And so when we use that word depression, we're not just talking about sad feelings. What exactly is depression?
Well, there's different types of depression, and it's defined based on symptomatology, but also length of time with which you've been dealing with. And so, for example, my stepfather passed away in March of last year.
Oh, I'm sorry.
And
Gosh.
my mom just turned 82 a couple of weekends ago.
Mm-hmm.
And she is just now experiencing the sense of loneliness and grief, because initially when he passed away, she had so much support from family, friends, and people coming around and visiting that she really didn't notice much. But now, as time has gone on, and she's gone through the holiday season by herself, now the grief and depression is really affecting her. And the depression caused by grief, they say that it lasts 3 to 6 months, but they've been married since 1980,
Right.
and they've known each other since 1974, 73, 74. So to say that your spouse of 40 years just dies, and you're only going to be quote unquote depressed for 3 to 6 months is really unrealistic.
I
agree.
Mm-hmm.
So you have to take every case, everything on a case-by-case basis, and determine, whether it's pathological and it's affecting their activities of daily living, if they're not eating, if they're not bathing, if they're not socializing, if they're not going out, which that's not the case for my mom, for example. When I go there, yes, she's depressed, she's sad, and when I leave, I see her demeanor change. But it's not that, she's not bathing, she's not taking care of herself. The house, it hasn't become a buried alive, hoarder type situation.
Right.
But so it depends on the situation and the circumstances.
So in that case, when should people seek help? When does it get to a point where this is depression, it's a disease, and you really need to find some help?
When it gets to the point where they are no longer able to participate in life as we know it, they do not get out of bed, or they do not take the clothes that they sleep with off, or do not leave the house, or are in a constant state of funk, or just inability to engage in any activity. I've heard stories of individuals that for weeks and months, all they did was, lay in bed and watch TV. Sometimes they don't even watch TV. They're going through their cell phone. Sometimes not even that. They're just sitting there or laying there in a state of, almost incoherent, because they're just so overwhelmed with the level of depression and the thought processes that are controlling and dominating them.
Right. So, in the US, frequently physicians that, go right to use of antidepressants, right? So let's talk a little bit about that and whether that's really treatment that is the best course of action, and how do they work too? I know they're all different, so that's a big question. But
The most commonly used antidepressants are the SSRIs. These are the serotonin reuptake inhibitors. They have found that when serotonin levels are low, that people tend to experience high levels of depression. And so the purpose of these medications is for the body to not utilize or allow for levels of serotonin to be a little higher
mhm,
and keep them from dropping. And by keeping them from dropping, it will ward off or fight off depression. The challenge with a lot of these medications, this specific class of medication, or the SSRIs, is that they usually take about 2 weeks before you actually see an effect.
mhm,
And it's a lot of trial and error. You start with one medication, tell the patient to come back in 2 to 4 weeks. You have them keep a log in a journal to see how they're doing. When they come back after 2 to 4 weeks, if they come back,
mhm,
and now you go into, so how are you doing? The most common side effect of antidepressants is depression, followed by suicidal ideation, followed by decreased libido or decreased sexual drive. Some antidepressants, for example, Paxil, causes anorgasmia in women and erectile dysfunction in men. Now, if you're depressed
yeah,
and the one thing that you have going for you is your, somewhat of a healthy sexual appetite, or some type of a sexual relationship with your significant other, now all of a sudden you're depressed, and this medication is further worsening your, or taking away the one little bit of enjoyment that you have in life, which is
mhm,
your sexual relationship with your significant other. Now all of a sudden you're looking at a greater sense of, depression. Some people talk about becoming apathetic, where they have zero emotion. They, when they're
wow,
on these antidepressants, it just
mhm,
makes flat and stoic, and they're unable to engage in any type of um, emotion, for lack of a better description.
right,
um, the other types or class are the SNRIs, which are serotonin norepinephrine reuptake inhibitors. These work on norepinephrine, which is a hormone that's produced in the adrenal glands, two small glands that sit just above the kidneys, hence
mhm,
suprarenal or adrenal, renal being referring to kidney. So it's in the area of the kidneys. That produces epinephrine, norepinephrine. And so this medication is a norepinephrine reuptake inhibitor in conjunction with a serotonin reuptake inhibitor. Um, Examples of that are Effexor. I'm using the common names because people tend to know those better. So Effexor, Cymbalta, Pristiq are examples of that class of medication. There are other antidepressants that work on other receptors in the
mhm,
brain to offset the depression and address them. Studies have been done for years now in many of the Ivy League schools, utilizing an anesthetic that causes dissociative properties known as ketamine.
mhm,
Ketamine I used to use when I was in training, when we would do DNCs in women that had spontaneous abortions or miscarriages, and you needed to go in and perform a DNC to clean out the cervix, then uterus. And so they would give them this medication, and it was a relatively fast anesthetic, but at certain dosages, uh, it causes a dissociative state and works as an NMDA inhibitor. It's a specific channel in the brain, and has been used for treatment resistant depression as well as
mhm,
suicidal ideations. And the protocol that's utilized is the Yale protocol, which comes from Yale University, where they treat these individuals twice a week for 3 weeks. And they have found that 95% of people that undergo this treatment re- go into remission for their depression.
Let's move forward and talk a little bit about cannabis and plant medicine. Do you feel that use of cannabis might be a better choice for some people, and how does it work?
Well, we have endocannabinoid receptors in our body. We have an endocannabinoid system. So before we speak on how cannabis works, we need to understand that we have receptors in our body, just like the receptors that we mentioned briefly earlier. We talked about the serotonin receptors. We talked about serotonin. We talked about norepinephrine receptors. We talked about NMDA. And so we also have cannabinoid receptors. These receptors are receptors where cannabis works on our, within our body. Now, understand that we produce cannabinoids in our body that work on these receptors. Not the same structures as THC, which is the most commonly known and understood phytocannabinoid, phyto meaning plant, cannabinoid meaning that it works on the cannabinoid receptors. So you have a phytocannabinoid, which is a cannabinoid that comes from the plant. But then you also have the endocannabinoids, and these are the cannabinoids that are formed in our body. The first one was discovered in 1992 called anandamide. So you can tell that this science and the discovery of these receptors is relatively new. 1992 was when I graduated from chiropractic school in Marietta, Georgia. So it's not been that long ago. And then 5 years later, due to the frustration, limited scope of practice, I went to medical school and became a medical doctor. So the use of cannabis has been used for anxiety, for depression. Many of my colleagues are of the belief that, if they use cannabis, it's going to make them more depressed because they think that cannabis is a downer. What they forget to understand is that phytocannabinoids have different reactions in our bodies. We also have a component called terpenes in the plants. These terpenes are what give the plant the smell and taste. So you have some terpenes that have a smell like citrus, which is called limonene. You have others that smell like pine, called pinene. So there's different types of terpenes, and all together, the terpenes together with the phytocannabinoids, you get what our Professor Raphael Mechoulam, who is the pioneer in this space, talks about the entourage effect. An entourage effect is when you get all of these substances working together, kind of like an orchestra in our bodies working on these different receptors. And by working on these different receptors, it allows for different sensations to take place. And so for this reason, cannabis can help with depression. And we've found that we can take people off of the traditional antidepressants and allow them to just use the cannabis, which has minimal to no side effects. And people are able to enjoy life much more so by utilizing the cannabis than by using these traditional conventional antidepressants.
And they don't have that same, the side effect of depression and suicidal ideation from the pharmaceutical drugs that you mentioned. We don't get that with cannabis. Is that correct?
That is correct. Yes, ma'am. That is accurate.
And so I know I've interviewed you before and had you explain how it actually works, why it works for depression. And I'd love for you to do that today as well.
Sure. So when we talked about the production of endocannabinoids are produced when we experience some type of stress. Now, it doesn't have to be a negative or an adverse stress like anxiety, depression, anger, pain, etc. It can be a good stressor, such as exercise or an orgasm. Any type of stress will cause an action potential. That action potential, what that does is it's like an electrical charge that makes its way down a neuron or a nerve cell that's found. So let's imagine that my two fingers, one is a presynaptic neuron, and this one is the postsynaptic neuron.
Mhm.
And they're called that way because between the two is what's called a synaptic cleft. It's a connection. And so when the action potential starts at the presynaptic neuron, it works its way down, makes its way to the synaptic cleft. At that area, at the presynaptic neuron, there are channels and causes a stimulation and a release of sodium, potassium, calcium crossing the synaptic cleft, and at the postsynaptic neuron, it causes the releasing of the endocannabinoids. The two most
Hmm.
commonly known endocannabinoids are anandamide, which I mentioned earlier, and 2-AG. They're produced at the postsynaptic neuron, and they move retrograde or in a backward direction to the presynaptic neuron where the CB1 receptors and CB2 receptors are located. And these endocannabinoids go back and work on these specific receptors. Now, between the pre and postsynaptic neurons, you have enzymes that are lurking around.
Mhm.
One is called FAAH, fatty acid amide hydrolase, FAAH, also known as FA, and the other is MAGL. Each one of these attacks the two endocannabinoids. So FA attacks the uh, anandamide, and
Mhm.
MAGL attacks the 2-AG and cuts their lifespan. Now,
Hmm.
phytocannabinoids, two specific phytocannabinoids, act to deactivate the action of the FA and the MAGL.
Mhm.
The phytocannabinoid that attacks the FA is CBD, and the phytocannabinoid that attacks the MAGL is THCV.
Mhm.
And by going in and taking in these phytocannabinoids from the plant, CBD and THCV, it blocks these adverse reactions of these two enzymes, and it allows for the full expression of the endocannabinoid system. Now, as we
Nice.
get older, or if we're under an inordinate amount of stress, now, anandamide is called the bliss endocannabinoid because it comes from the Sanskrit word ananda, which means bliss. So
Mhm.
it's the bliss endocannabinoid. That's how you're supposed to feel. So as we get older, we produce less endocannabinoids. So for this reason, we need cannabinoids from the outside or exogenous, from
Mhm.
outside in to work on these receptors.
I love it. The word anandamide is bliss. So how can it not help with depression, right? It seems like it
Exactly.
was just built for us and we're built for it. I guess, for people who are listening and watching, as we said in the beginning, the depression is so prevalent. People are going to their doctors and talking about it. Most of them are not trained and know what you described, how the medicine works for depression. What can they do? I know even at the doctor's office they're testing people now to figure out which antidepressant works with their body, which is a little better than the trial and error we had before. But it
True.
sounds like these drugs don't really do the full job where cannabis could for many people.
I mean, I've heard Professor Hanush, who was the gentleman that named the first endocannabinoid and wrote the foreword to my book, Hope in Healing the Case for Cannabis. But from stage, he has stated himself, cannabis doesn't work for everybody. So, you know, I don't want the message to be muddied or muddled, and people think that, oh, cannabis is a panacea and it works all the time.
Right.
It doesn't always work, and it doesn't always work the same way on everybody. And so, as I mentioned earlier, it's an individualized medicine, and so we must treat it that way, and we must be conscious of that.
So are there lifestyle changes that people can add in? I know, when people are depressed, you described the symptoms in the beginning. It's hard to get going to make some changes that might help. But once they're on whatever type of medicine they choose, What kinds of things can they do? Are there diet changes, or what would you recommend?
There's some plant medicines that are being studied and investigated, such as mushrooms.
Mm-hmm.
And there are certain states in the United States that have decriminalized and or legalized the use of uh, mushrooms for the treatment of depression. And there have been
Mm-hmm.
articles in a lot of the mainstream journals out there, Newsweek, Time, etc.
Mm-hmm. Yeah, I have used psilocybin myself, microdosed, and it's very interesting. Microdosing for a short time, it seems to last for a really long time, even when would stop microdosing. I think there's a lot of hope in that. What do you think?
Well, it's plant medicine. And so we have those same receptors in our bodies that work. There are some,
Mhm.
cannabis physicians that also push and promote the use of microdosing of cannabis, two of which are Dr. Ethan Rousseau and Dr. Dustin Sulak, that
Mhm.
both have, been very verbal and in teaching and educating using 2.5 milligrams of cannabis 2 to 3 times a day,
Mhm.
and progressively increase, titrate to effect. But they want everyone to be on at least 2.5 milligrams 2 to 3 times a day, because they feel that that's sufficient to stimulate the endocannabinoid system.
Wow. So much progress. It's good to hear. And and that microdosing, a lot of people will say, well, I don't want to get high, right? It's a side effect of the medicine, right? So by microdosing, maybe they don't have to deal with that side effect so much if that's not what they're looking for.
Well, the thing is that when you have clinical endocannabinoid deficiency that's causing post-traumatic stress disorder or fibromyalgia symptoms or bipolar disorder or anxiety, depression, etc., you need so much cannabis to maintain your levels at a therapeutic index.
Hmm.
And so the probability of you being high or stoned is minimal to none, because it's medicine and you're taking enough medicine to offset the effects of whatever pathology you've got.
Very good point. Oh, this has been fantastic. Where can people get in touch with you if they want to learn more?
Sure. They can go to my website, www.josephrosadomd.com. That's josephrosadomd.com. If they want to send me an email, they can go to, they send an email to info@josephrosadomd.com, info@josephrosadomd.com. I am on Instagram, Dr. Rosado, Dr. Rosado. I'm on LinkedIn, Joseph Rosado, MD, MBA, Joseph Rosado, MD, MBA. So those are the main places where you can find me.
Excellent. And if you could mention your book one more time as well, that would be great.
Sure. It's Hope and Healing, The Case for Cannabis. It's available on Amazon. Uh, on Kindle, it's $5. Paperback, it's 20. Hardcovers, 30. It's also available at Barnes and Noble, as well as Roku. So there's different areas where you can purchase the book.
Excellent and affordable for anyone, really. That's
Yeah, I mean,
wonderful. Mhm.
$5 for a Kindle book, you
Yeah,
can't beat it.
you can't beat it, and it's great information. Thanks so much for joining me.
Always a pleasure speaking and meeting with you.